found my number.
Yes, and you came very fast.
Yeah,
And oh, that's great. So I'm in a Zoom meeting here.
Okay.
And I'm hoping the presenter will join. I'm going to pause the record.
So introduction to the panel, and then each of us does the agenda piece, and then we talk.
Okay.
Does that sound okay?
Yes. Should I introduce?
I can do it.
Okay.
So welcome everybody. We to this panel called Reimagining Anthropological Engagements with the Health Sciences in the COVID-19 Era. We thought of this panel in 2019, presented it for the conference that got canceled, and then represented it for this conference. And the reason that this panel came together was this discussion of there's a lot of anthropologists who are now working and engaging very actively with the health sciences, but not a lot of dialogue about what that means in terms of our relationships with the health sciences, in terms of the epistemological differences and how you manage those. And we thought this would be an interesting sort of way forward to sort of do a little bit of thinking about that. So we have 4 presenters. Each of us is going to talk a little bit about their perspectives on how these engagements have happened in their careers. And then we will have some other questions that we thought we might tackle, and then we can just talk. Does that sound good? So Mark, you are going first.
Thank you.
Do you want to introduce yourself first?
Yes, I'll introduce myself. So welcome to the panel. You are representing the multitude.
You're the VIP.
That's right. You are in the VIP level. All the others, the white collar must be in the back there.
So, Mark, can you speak up
Oh,
to
okay.
the computer, because we have rather limited technical.
Jason, can you hear okay?
Yep, I'm fine.
All right. Good. So just really briefly, my background, I am a professor in the Department of Prevention and Community Health at George Washington University, the Public Health School. I also I have an appointment in the Anthropology Department and the Elliott School of International Affairs. And when I was doing my PhD research, I actually wasn't thinking of going into public health. I mean, that wasn't primary on my mind, but my interest area was in sort of cultural formations that grew out of concentrated poverty settings. And so at the time, there was, still a lot of funding for HIV. And so, this was after Columbine shooting, and so there was a lot of funding for violence prevention, substance use, and violence prevention. So, so a lot of the populations that I would be working with were, sort of syndemically involved in all of those, and so that kind of just pointed me right into public health. So I did a lot of HIV work for a while with runaways, working with crack and injection drug users, and these were all evaluations of prevention programs, some sort of basic behavioral research of risk patterns, things like that, among some different populations. And then this a lot of work with violence, substance use, and more recently, I have 2 centers. One of them it's called the Avance Center for the Advancement of Immigrant and Refugee Health. So I work with a lot of primarily Central American immigrants right now, but also been branching out to this big Ethiopian population, West African population in the DC area. And we have had several NIH and CDC grants to look at, to put in place community-based interventions and, of course, do the research to see if they're effective, related to diabetes prevention, to prevention of the co-occurrence of sexual risk, violence, and substance use in Latino youth, and some other projects like that. So there's been a series of those kinds of projects. And the other little center is mostly global, and I do a lot of work with UNICEF, country assessments, things like that, all of which I use all the background from anthropology. It's all, most of them are, the causative model and community intervention is usually developed from the community, from qualitative formative research, and then we put that model into an intervention design and testing. So the anthropology connection has been, and again, I many things I will say are this was not a strategic plan that I had figured out, when I was in the PhD program.
Yeah.
It's sort of, the opportunity kind of happened this way, it happened that way, and it's and that's how things happen a lot of times. So that's basically my background. So I still sit in the public health school, and I collaborate with the anthropology department on several things. We've had some small grants to do life history interviews with recent migrants, looking for social determinants of health, and things like that. And in the setting that I'm in, I am the only, there are 7 departments in the public health school. I am the only anthropologist in any of those departments. There was one other person in global health, Reyes. So it is a funny position in some ways, but in both directions. And I just kind of mapped out kind of three ways, and this is based on my experience. So I hope nobody minds me using myself as a model here. And I don't mean a model in any apple polishing sense. It's just this is how things are. Sort of 3 domains of how me as an anthropologist has intersected with the public health context, the public health academic context. So the first domain is no surprise, is teaching, and there I teach several courses. I teach a course in culture and health, which is basically a mid-anthro course for non-anthropologists. I teach the doctoral social and behavioral theory course, which I always have to, kind of, it's amusing that I am teaching that, but I am. And I teach courses in qualitative research, some at the doctoral level and at the master's level. And one of the things that just happened was that at GW, they have a pretty strong undergrad public health program, and it was kind of, when I got there, it was still in its relatively early phase. So there were a lot of courses that need to be developed. They wanted to have a social behavioral theory course for undergrads that would also count as a social science credit. So that allowed me, in the developing that course, it allowed a lot of room for, the introduction of, segments where we looked at the epistemologies underlying the theory that is in public health. So it allowed for that, because it's going to be social science credit. So that course ended up being developed. There was no textbook for it. There happened to be a textbook publisher who was a former dean at the public health school there, and he asked me if I would write a textbook for that. And I have it right here if you want to look at it. And it's now in its 3rd edition. So that was just, again, an opportunistic thing. And then I moved from doing that. I designed the doctoral course, or revamped and designed that course too. So I ended up teaching those. So there is that role. And in all of those courses, I have tried to, inject an anthropological perspective, even in the theory course. I mean, we do the canon of social behavioral theory and public health, but we move beyond that. We talk about anthropotheory, we talk about culture, the role of culture, we talk about structural violence, we talk about political economy, we talk about syndemics, all of those things that move out. So that is definitely one way where you can, put yourself in that role. The culture and health class too is another class I developed, and this is again because, like any university, I mean, they're on the track of trying to find ways of incorporating diversity, inclusion, and that course sort of, I proposed that course. There it is, and the books were mid-anthro books, and those were not quite appropriate for the public. So that publisher said, "Go ahead and write a proposal." So there you are. So that's one domain. A second domain is just, in terms of, well, actually still under the teaching domain, it's faculty issues. This just, this is a headache for a lot of anthropologists in public health because the publications requirements and things like that are different. I mean, the best of anthropology journals has maybe an impact factor of 3 or something, and so your H factor and all these other things upon which people look at, for tenure and promotion, no matter what, it's not gonna compete with an epidemiologist who's writing, 15 papers off one data set. So, and plus, I mean, we write books, we write, other things like that, and it just takes a lot, as we all know. I mean, I could have a sample size of 30, and it may have taken me, 6 months to get that sample of 30. So, I'm on the APT committee now. So a couple of years ago, I managed to the eye rolling of some colleagues, but I managed to put in and get approved a paragraph in the APT criteria that recognized, because it is there's a lot of language about this being a cross-disciplinary field in prevention community health. So I said, if you're going to have a cross-disciplinary field, you need to recognize the publication standards of the home discipline. So that is now in there. So someone can appeal to that when they're writing their. So that was another way, and then I'll just try to quickly go through a couple of the others. And then the other part is in sort of the public health research, and I mentioned some of that already, but I mean, I think anthropologists can play a huge role, particularly with community-based or community-engaged research in the research design and what questions are asked and the methods used. If you are able to get those funded, I mean, it's just the pragmatic thing. You get some funding, and then they see that you got funding. So it ends up, right off the bat, legitimizing, what it is that you just got funding for. So, and the methods used and the approach. So I through the Amapse Center and before that, we had a lot of community collaborative research, and it did get CDC funding. We had a CDC REACH grant, racial ethnic approaches to community health. That's a long-standing community based funding mechanism. We've had several grants, including the Centric grant from the National Institute of Minority Health and Health Disparities, and other. We have a CDC youth violence prevention grant. And all of those were community-based. All of them used mixed methods and used, sort of qualitative formative research to help orient. So those are sort of like, I mean, those are, now there's like a string of those projects, and some of those involve other faculty. So that ends up, working too. And with the global projects, a lot of, like I said, have been with UNICEF. One was with the Gates Foundation, and that was sort of phase 1 of a longer project, but that was the ethnographic qualitative phase in Ethiopia. So that is a second way. If you're able to get any funding like that, then you're injecting yourself into that public health setting, and people will then, it helps people listen to you. And the third domain, kind of the corollary of that is, as much as possible, and this can be very frustrating, but trying to get the research put in public health related journals as opposed to just anthro journals. And that, that can be, the only thing I would say there is drink some Zen juice or something. I mean, because it may take multiple tries, because your sample sizes may not be that huge, and you can't do a power analysis of your sample priori, things like that. So, but I would just say, keep pushing at it, and there will be some journals, like we put things oftentimes in primary prevention journals, Journal of Immigrant and Minority Health, and other journals like that, where the topic area is so those were sort of 3 domains. If anybody wants to look, those, just to see those, I brought it again, not much on my own Apple, just to see, these were some articles that went into public health journals that were specifically an anthro perspective. One of these, for example, there's a lot of buzz around social norms theory. There's a lot of these theoretical buzz phases that public health goes through, and so there were several faculty who were very much into social norms related interventions, and so with another colleague, we wrote a critique of social norms theory that took 4 tries to get that into a journal. but it did. It finally we got it, and so we have that, and it's called recontextualizing social norms construct as applied to health function. It's distinctly we have it in there. This is an anthropological take on this. So anyway, so there's just some examples of that. If anybody's interested, these are all sort of anthro perspective type articles. So anyway, those were the 3 domains I was thinking of in terms of how you would get yourself into that full concept.
Jason.
Okay, great. Thanks so much. And sorry I'm not there in person. I'm a medical anthropologist, but I'm also an emergency medicine doctor in Tampa, Florida. And so as everybody knows, as we organized this panel, it was right during the this coming pandemic that we didn't know was coming yet when we started organizing this. And obviously it's been the last 2 years of my life now. So it was obviously difficult to travel if you think about Florida and our, COVID numbers here and what my role has been kind of day to day. But yeah, I really did want to stay as a participant because I think this panel is critically important and is kind of the goal of the work I'm doing is to show value to the world of what medical anthropology brings to the table and how it not only affects and impacts research questions, but can also really give us new ways to do clinical care or see clinical care as well. So I'll just kind of talk through the story. I went back to the original emails a couple of days ago when we were making this panel, and I was like, "Well, how did I get involved in this panel?" And I remember that Adam Van Arsdale, which I'm happy to be. I was like, "Where did this come from?" So Adam Van Arsdale, who was my roommate or really good friend in grad school at Michigan, was the bioanthro chair at AAA when this all came together, and I reached out to us looking for people, in outside of anthropology departments working in anthropology with some kind of health perspective, which is really that has been exactly what I've been doing for my career now. So to give you some background as just way of introduction, some of this will sound similar to Mark. It'll just come from a traditional, more MD type of perspective of that same type of work. I'm on the medical school faculty here at the University of South Florida, where I do both medical education and also work clinically as an emergency medicine doctor. And then I'm the research director, which means as you've now started, I think this is important to hear these like unifying themes that kind of pop up where there might be work or things that anthropologists can do. So one of these themes is that, the AAMC, the governing body of residency curricula, mandates these scholarly activities for residents. And, this is just for setting expectations. This is not going to be like what you'd expect out of a PhD student or even an MA level student often, but they do have to do something. And so, I'm involved in designing what that something is for both our emergency medicine department and also more broadly internal medicine, and making sure that those, projects and criteria are met. And then, of course, I have my own research design, research project as well, which I'll get to as we kind of walk through this a little bit. So let me kind of explain what I mean by how I have try to bring in an anthropological perspective, but how I also formally have utilized anthropologists, utilized my own anthropological training, where that sits now and what that kind of looks like. If you go back to about 2014, 2015, I had become fairly frustrated with clinical trial research and clinical the way we approach research questions in clinical medicine. So I had, been the PI on a bunch of clinical trials. It was kind of the same question every time. I'd had another negative study around sort of the same disease state. We basically asked the same question with a number of different drugs and had negative studies. And, this seemed a little futile. And I'd been out of residency for a long enough time too, to really have a good grasp of where this world was with patient care. And some of that seemed a little futile in the sense of kind of doing the same thing over and over again, the same exact way. And, it made me start to think back to my anthropology training, and what that training was, just so everybody knows, is I had gone to Michigan to do a PhD in anthropology, and then actually left at that time, ABD, to go to medical school. And you're going to hear the circuitous route about how we come back to this. But, so I had this, training in graduate, in graduate school with anthropology, and it always has sat there. And, I'd asked this question, is there a better way to do some of this research? And is there a better way to approach some of this patient care than what we're doing right now? And, really, there was not a very good understanding of qualitative research. And that's actually increased, I think, actually gotten much better over the past five years or so in general. But there really was not much understanding of qualitative research or what a anthropologist could bring to the table and thinking about a clinical scenario. So the other thing that was happening pretty often was that I had a lot of undergraduate students coming to me and wanting to do things to get ready for medical school, right? To apply to medical school. And there's kind of this like assemblage of things you're supposed to do to get ready for medical school. You're supposed to do some kind of research. You're supposed to shadow, which usually means traditionally a shadow physician. I'll come back to that. And then sort of spend time in some kind of clinical space and kind of get an idea of what you're doing. And so we'd have these students come in and they would, do a project to check a box. And I don't think they had much engagement or fulfillment from it. And it was really more of a nuisance, or it just wasn't very fulfilling for either of us, I think. So I started thinking too, is there a way to integrate anthropology, ask anthropological questions, and maybe figure out a way to deal with some of that as well? And so Roberta Bear, who's anthropologist here at USF and is a medical anthropologist, I reached out to her. I'd known her for a long time, and we sat and we kind of talked through it, and we designed an undergraduate course. And we designed the undergraduate course specifically for, we both had slightly different motives around the course, but we had similar motives. And what I mean by that is Robbie's motive really was, yes, medicine is being done the same way over and over and over again. Patient experience doesn't improve because there's no perspective around a patient lens. And if we could bring some anthropological thinking into physicians, into the way we design clinical care, perhaps we could change that. But her experience, and I think is fairly accurate, is by the time you get to mid-career physician land, you're so encultured in a biomedical space, it's going to be really hard to move out of that or change the way you do things. And so her thought was, if we could get at undergraduate students who had a really, really, really high probability of actually going to medical school, right? There's a lot of pre-medical students, and then some small percent of those go to medical school. If we could get at those students, then maybe we could start to make an impact. And so we designed this undergraduate course and went to the honors college at the university and, pitched it. And it was sort of accepted as like one of the courses they could take as one of their capstone requirements. And it gave it a space. But it also gave it a space and a group of students we felt that would have, again, high probability of going to medical school, which meant that we were making some impact at a key critical stage in their training. And so this is spring of 2015, we first teach the course. And honestly, we were thinking we would get, maybe we'd get 10 people who wanted to take the course. And just to level set what the course design was, the whole idea of the course was to put undergraduate students into a clinical space and to put them there in order to meet some of the criteria they had to meet to go to medical school, but to also have to, do a course with Robbie and I every week around medical anthropology and really around understanding both, structural determinants of healthcare, but also, culture and climate and, that Han, and really kind of understanding illness versus disease, if we really go back to that. And then, the concepts like Magrath, structural violence and those kind of things later in that course, but really at least getting an understanding of like illness versus disease. So lecture format, but also clinical scenario, like clinical setting. And the way I kind of thought about that was, well, they all want to do research. Is there some way we could teach anthropological research, qualitative or mixed methods research to this group of undergraduates? Because I couldn't get my residents to do some of the stuff anyway, right? I really, going back there, right, I had some frustrations with, trying to get some of my residents engaged and maybe wanting to do some mixed methods or qualitative work. And, the interest level it was hard to maintain. But we felt we could probably get some of these undergraduates to do some mixed methods qualitative work with our guidance. So, and they meet their criteria. So a pretty novel concept of putting these undergraduates right into a clinical space, into an emergency department, into a level 1 trauma center emergency department. And so we thought we'd get 10 people or so. We ended up getting 100 people who wanted to take the course the first time we taught it. Obviously, we couldn't take 100 people into the course. And so it ended up being a fairly competitive course to get into with, an ad hoc application essentially that had to be designed. And so we took 10 people into that I think we ended up taking 12 people into that first course, designed a group level research project looking at expectations of patients in the emergency department, getting through IRB, getting through HIPAA language by, while emphasizing concepts like participant observation and deep hanging out. So we just doing that, we felt like we had made some pretty, substantial ground move because we had basically gotten IRB to let, anthropologists come in and sit in a waiting room of an ER and record things or write things down and talk to people about things. And, what we really focused on for those first 2 or 3 years of the course was figuring out gaps in patient expectations versus clinical reality, and if those gaps might lead to dissatisfaction around patient experiences. And that led to a couple of very cool things. That led to one, this emphasis we started to make on patient shadowing as a different concept around learning clinical, having a patient-focused lens early in clinical training. And so we started doing required patient shadowing for these students, which means they would basically just hang out with the patient from the time they walked into the waiting room until they got dispositioned to the emergency department, which either means getting, discharged home, getting admitted to the rest of the hospital, or going to some procedure. So you kind of hang out and watch that entire case unfold. And I'll tell you, this continues, and we've expanded this. I'll get to that in a second, but this continues to be one of the most impactful things that we could possibly do. And, it's been 7 years now since we first started teaching this. And I have students now who are in mid-residency, right, who are undergraduates with us when they took the course. I survey them every year. They fill out a survey, a longitudinal survey of this cohort. So these cohorts that come through, and this continued their experience in that room, when they were 20 years old, basically with us doing patient shadowing, continues to impact their career, their lens, and it's usually a sort of a life-changing experience. And these are, even through residency, you've got to remember these are people in their early to mid 20s who often have not encountered the healthcare system through illness. And if they have encountered the healthcare system through illness, they may have encountered the healthcare system through illness by really their either family structure of having other physicians in the family, or but in probably different ways than what a average emergency department patient might face with all those structural determinants, structural violence pieces that they're bringing to the table. So it's a very different experience and kind of a world-shaping experience. So we feel that that is critical. We've actually, just to give you an idea, we've pushed up patient shadowing now to even our residents, and we do a resident workshop for the internal medicine residency and for the emergency medicine residency of doing patient shadowing, and they hate it. They hate it, and then but after it's done, it still continues to be impactful for them, and they all find value. But when you tell them they're doing it, they're just, I mean, because if you think of when you're a resident, when you're a resident training, in medicine, you're in the hospital all the time, right? I mean, it's less than it was when I trained, but you're still there a lot, and you feel like you're the doctor, and you feel like you know all these things, and the last thing you want to do is put on normal clothes, which is what we have people do. We don't want them to be doctors, and we want them to be interlocutors, right? We want them to just sort of blend in, so put on normal clothes and go sit in that same exam room that you might walk in every day and see patients, and sit there as a patient and see that lens. And the things we have found, action items, right, that we have found through this approach is invaluable. I'll come back to that. We talk about how people respond to some of the work we do, but key insights, that we have found kind of through doing that type of work. So the undergraduate course was really kind of the beginning of structuring how we brought in anthropology, really through that early undergraduate education, thinking about how to impact medical education. And then that's starting to extend into not just the undergraduate space, but like I said, the resident workshop space, that we have a first year medical student elective they do throughout the entire, they can pick one sort of elective they can do throughout the whole year. So we have an elective based course that undergraduate medical students do, where they do more of this type of work. And then what's been very cool the last 2 years is we've begun leading faculty level workshops. And Mark, the same questions that you ask around race, we ask very similar questions and get very similar answers, even to full professor faculty level physicians. So we find a lot of value in doing those types of workshops each year as well. So that space has worked really well. The research that's come out of that has been pretty incredible. We were able to both apply a change by creating some patient-facing material, just based really on data collected from patients around expectations and realities of what the emergency department visit looks like. And we really focused on those non-sick patients as we got used to IRB and HIPAA and everything those first couple of years. But we've pushed this incredibly over the past few years. We pushed into looking at non-fatal firearm injuries and interviewing those patients who've been affected by firearm violence. And that really just grew out of frustration that, we were actually teaching the course when Parkland happened here in Florida. And, we realized that we see firearm violence all the time in our ED, and we have this, ability to do research, and we need to do something with this because, right, we can, and we should act on that. So we have, and we've got this incredible collection, of over 100 interviews now of non-fatal firearm injuries from people who are in the ER, all about their views on gun policy and their views on what could be done to prevent this from happening to people like them in the future. And that's been great. Then the other structural thing that happened was, of course, these undergraduates are taking the course. Some of them want to continue doing some of this kind of work. Sometimes that's formally, and it's through an undergraduate honors thesis. And what was happening was Robbie and I were kind of getting, students from the course at different kind of trajectories of where they were in their undergraduate education approaching us. And we were both having multiple undergraduate honors thesis students and kind of reinventing the wheel over and over and over again. It was a lot of work to just sort of do the same thing and, over and over and over again at off timing for these students and to come up with projects for them. And so after about 2 years of teaching the first undergraduate course, we actually started teaching a second undergraduate course, which was really a health science research course around these people who want to do honors theses. And so we would take a subset of that first course and put them in the second course, and they would do a thesis with us with a pullout of their own mixed method. And really the focus was on mixed methods, qualitative research projects with some, not tricks is not the right word, but ways to approach IRB that were really, really useful, longitudinal projects in IRB that kind of stayed there. And then what the pivot point, I think, that's really changed things in this last few years has been as we recognize value of what anthropologists could bring to really important questions like non-fatal firearm injuries, we also recognize that it's great to teach undergraduates, really happy to do it, cool to have them out there, hanging out, doing some observation, but they didn't really have the skill sets to really get at, right, some of the ethnography we wanted to get at with these questions around firearm injuries. And so, started to think about how to maybe bring in some, PhD students and graduate students into the department. And then my own work was evolving as well, really starting to, what I do clinically is build out clinical pathways. That's one of my administrative roles. And then, the question became, can we utilize an anthropological lens to help us build out clinical pathways? And so formally, what does that mean? That means taking concepts about, things like Alex Nadine's written about or Anna Singh's written about around just how things form and how assemblages come together and how pathways kind of create. And can we use some of that theory and thinking to apply to a clinical setting, to build out clinical pathways? And so I actually brought in my first PhD student in 2016, Heather Henderson, who has helped us build out an opioid pathway, which has been incredibly successful and, led to a lot of other research and mixed methods work. So just briefly, we really, going before 2015, and Florida is sort of the epicenter of this opioid ongoing, worse, actually, new data yesterday showing it's even worse now with fentanyl overdoses, leading to over 100,000 deaths last year. But going back to before 2015, a patient comes in the emergency department with opioid use disorder. We really did not do much for that patient. We basically gave them a handout of resources, said good luck, goodbye. And, my clinical care led to the deaths of a lot of people just by ignoring that population and reifying a disparity in a vulnerable, set of people for 10 years, of my career. And the question was, can we do something better? And what an anthropologist has really helped us do, who is really focused on not just the patients and kind of what that looks like. And, she has her own interest in learned helplessness and how to approach an opioid, use disorder patient, but also around providers and how can providers move from doing something way over here where they don't even see this possibility or potentiality over here to getting to a place where this becomes the path of least resistance. This becomes the obvious way we should treat the patients. And that's what Heather's been able to do over the last 3 or 4 years, is transition us from not doing really much of anything for the opioid use disorder patient to having this like complex assemblage of tools, using a medication called buprenorphine, getting our providers licensed to utilize buprenorphine, working with an outpatient, substance use facility. This extends on having peers who are specialized, people who've had addiction before, working in our emergency department, building all these things out, even to the point of having now, however, our second legal syringe exchange program in the state of Florida in Hillsborough County, run by us. And so this is all stuff that can't happen without an anthropologist working right in that space, kind of seeing the pathway, but kind of having not only meeting patients where they're at, but meeting providers where they're at too, and recognizing that need for confluence. So we've had the PhD student. That was our first PhD student. We've had a couple of other students now. We've had another PhD student work on low English proficiency patients in the ER, published 4 or 5 papers around that. It's been great work. It's even led back into my own completing my PhD around, extending syndemics into a model of treatment around Hep C and opioid use disorder. And so now we have a pretty fully functioning both medical education curricula, but also we have 2 PhD students. We have a postdoc PhD student. We have a PhD level former faculty person working basically with us now. These are all anthropologists, and we just brought in my next, for next year, another anthropology graduate student. So, which is always an awkward place. I finished my PhD now, and I've got my graduate students. So welcome to the awkward world of anthropology. anthropology, right, for a year. Almost done, so should defend soon, and that'll make the awkwardness less. Because I have a courtesy faculty appointment over Anthro too. But it's we feel like we're getting to a place now where there, and I'll talk about that in the second question, where we're starting to have a research agenda and an education agenda that clearly places anthropology as the thing that we are doing and bringing value for clinical medicine. So I'll stop there and talk about some more in the next two sets of questions.
Thanks, Jason.
Thanks. Hope everybody could hear me okay.
So interesting. Yeah. Thank you so much.
Yeah.
Thank you.
Really great.
So time is moving faster than we thought it would. So my name is Lucia Guerra. I am originally from Peru. So I come maybe differently, in a different perspective. I came to the US for graduate school. And when I came to the US, having been an undergraduate in anthropology, my interest was in health. And when I did my undergraduate sort of thesis for my anthropology degree, I had a lot of linkages or interactions with public health because my research was on women's decisions on birth care in the Peruvian highlands. And so, and my interactions with medical providers in that sense, they were not part of my research, but I went there because I accompanied some women through some things and I was just around, and the posta was the only place that had internet, and I'm talking like late 90s. So I sort of showed up and I knew some people there through organizational things. So the discussions that they were having with me about the research I was doing as a very green 20-year-old or 20-something-year-old were sort of led me to realize that we were speaking different languages, that there were sort of like very clear differences in ways in which I saw the world from an anthropological and a very nascent, very green anthropological perspective and the medical perspective. And so when I engaged then in a master's degree in gender, sexuality, and reproductive health in the university in Peru that has the leading sort of public health program there. It wasn't an MPH, but part of me was trying to re-engage with this research because I had been working in conservation. And it was nice living in the jungle, but my heart wasn't in conservation. And so I wanted to re-engage with health. And then when I finished that, I decided as a family, because I was married at the time, still married, to come to the US for graduate school. And so I was looking for a PhD that would allow me also to do an MPH that will help me understand the language of public health. Because my original idea was I'm going to go back to Peru and actually work with those baby doctors that I had met to sort of do some sort of, that's not what the world is, let me tell you please what the world is about. That was what I was thinking about, and that was a long time ago already. It's like more than 20 years ago. So when I did come to the US, I ended up finding this program which worked out perfectly for us. My husband was at Carnegie Mellon, he was doing statistics, and I went to Pitt, where we have a joint program, which is a PhD MPH. But it wasn't a really joint program, right? You did the MPH, you did the PhD, and every time I crossed the road, it was like crossing to a completely different world, in taking classes in a completely different world. And I really thought of myself as managing those worlds well, but I was really enjoying being the anthropologist. So I didn't really think that I would end up in a school of public health, but I did. We got jobs here, so we ended up not going back to Peru. And now I am associate professor in the School of Public Health in Indiana University, Bloomington. And the reason they hired me in Indiana University, Bloomington was, well, she has a PhD, it's in anthropology, but she also has an MPH. And the MPH kind of had this like little star around it. It's like, okay. So, but I thought over these past 7 years, and I only just made associate in 2019. So when we started having this discussion for the panel at Vancouver, I was just sort of processing how I had to present self as going through the tenure process and manage what I was seeing, this in-betweenness of self in a professional self, right? So, and so this is why I was thinking sort of like, how do you manage the in-between? Which is where I was then, and I'm sort of still now trying to manage the in-betweenness of it all. And so over these 8 years, I've understood my presentation of self in the ways that I've talked about myself to public health people, is saying, I'm interested in understanding the issues of marginalized women's access to sexual and reproductive care, which is what I would have said in an anthropology setting. But I also sort of add in, but if you think about the scope of public health, I'm the person who tells you and can do research and try to understand how complex things are. And I can tell you there's many ways in which these things are complex, but I'm not the person who's going to do the intervention. I'm not the person who's going to do the clinical trial. And so it is in this sort of but that my professional self sort of lives. And so I was reflecting on this, and these are the sort of remarks, the ideas that sort of came in the reflection. And one of these things is that when I sort of understood my colleagues, when they hired me, they had a very unclear, fuzzy knowledge of what an anthropologist did and what they were any good for, right? And there was sort of placing questions that I got as I was sharing with Priscilla and Mark yesterday, like, for example, what is your theoretical perspective? What theory do you work from? And I sort of threw me for a loop because this was pre-tenure with a senior faculty member. I was like, yeah, I don't do theory. Like I have questions. I sort of think these questions within a broader sociocultural perspective, hopefully within a critical perspective. I look for ways in which I can answer these questions. I find, organizations or people that I can help me answer these questions. And then I try to get an answer to these questions. And so there was this sort of, well, what do you do kind of thing, right? And so I think that my whole pre-tenure career has been trying to place myself in different ways that make sense for a public health audience to overcome this fuzziness and in-betweenness. Even though I still feel in between, they feel that I am less in between than I was before. But I had to do a whole lot of convincing, let's say. And one thing that I found useful and I thought I would share, just generally for people who are in the same sort of in-between spaces, is I actually actively and intentionally used field work, but institutional field work, to better understand how people saw me and how then I could respond. This sounds Machiavellian, I know, but sort of understand what the role was. And I also kind of used this space, these interviews that I did, which were really not interviews. They were like, hey, I have a research idea, or I have a research question, and I want to talk to you. And I would sort of take people out to lunch, like faculty members, senior faculty members, to try to understand what they did, how they saw me, but also to pitch who I thought I could be or who I was. And more specifically, I was pitching my book, because I knew that my dissertation could not, I mean, if I butchered in papers, it would not be as impactful as it could be if it was a book. And I just didn't see it being a series of papers. And so, but I knew that the book was a contentious issue in terms of tenure, because most of my colleagues do textbooks. So books are teaching, not research. And so I did use, in some sense, an anthropological strategy to orienting my career discussions in my own department and school over time. To be able to sort of manage that negotiation to establish what an anthropological identity could be for them, and also for me, and a space where I thought I could live both in these two worlds as a professional person. And so I think that sort of echoing some of the things that people have said here, qualitative research became one of the linchpins of what I did. However, I realized that while I had methods training in my graduate program, it wasn't the way that public health understood qualitative research. And so there was a lot more finagling in trying to establish that professional accolade or that professional star, this is what you do, in actually sort of retraining myself on the language that public health used about qualitative research so that I could make it available and knowledgeable for them, right? So because I was getting people who were saying, well, if we do all this analysis from the open-ended questions on a survey, that's qualitative research. And I would say, well, that's content analysis, which is a form of qualitative research, but it's not like, it's sort of in the middle epistemologically thinking from quantitative and qualitative, because what people do generally is quantify content analysis, right? So you end up with percentages and other things. So, but it did become sort of who I was seen as. Oh, you want to do research with qualitative, you want to do a qualitative dissertation, you have to have Lucia on your committee. Which led to some interesting discussions because I was brought sometimes on committees early on where I was the person saying, wait a minute, this is not how you do this research. This is not, so you're a Brahmin and your group is a Brahmin and you're attempting to do interviews in your area in India where your family is known as being the Brahmins and the higher caste people, and somebody else is bringing the interviewees to you. All of this seems very, very not what you should do if you actually want to have a very effective research perspective in what you want to do. So, so part of that over time, sort of as I have tried to move from the junior to sort of more middle career, has been the sort of pushing to negotiate for a more holistic understanding of what qualitative research is and what it entails and what it implies. In my department, so I'm part of a School of Public Health that has 5 departments, and within that department, the department where I work, the Applied Health Science Department, has the most faculty members. And a lot of, we have an undergraduate program, we have a master's program, we have a doctoral program. And so in my department, there has been a lot more recognition around that qualitative research expertise is one of the competencies that we want our doctoral students to have, but not at the school level. So at the school level, our dean, who is recent-ish, is much more interested in how much money you can get from NIH than he is on education broadly, and really, I would argue, on actually thinking about what community engagement and solving pressing issues in public health that we do have a lot of in Indiana. So, so this has been an interesting sort of thinking about, but this has been one of the linchpins in which I have been able to sort of make some forward movement. I now have a qualitative health, advanced qualitative health seminar for our doctoral students, which I teach, which is only in its 3rd year. So it's going to be in September, in the spring semester, in its 3rd year. And the other place in which I've been able to sort of inject some more of this anthropological perspective has been through engaging with the language of social determinants of health and the language of moving beyond individual level interventions to more structural and policy level interventions that has aligned really well with how the American Public Health Association is also sort of moving in terms of their discourse. I'm not sure if in terms of the practice specifically, but certainly in terms of the discourse of trying to engage with structural level issues rather than individual level interventions. And so I find that I'm able to talk about anthropological concepts when I teach classes. So I teach one of the cores of our master's programs that all master's students have to take. So from epidemiology to environmental health to our behavioral community health people, all of them take this class called Population Health Determinants. And I didn't make up the word, like the title, but it's like, okay. But we talk about social determinants of health. And in that, I talk about a lot of medical anthropology concepts and thinking about how we can move a perspective of public health beyond the disease and beyond the individual level. And I spend a lot of time trying to talk about beyond the individual level. However, still the majority of what my colleagues do, both theoretically and also in the theories course that I do not teach, but that also people take in our program, is talk about the individual level theoretical perspectives. So different than Mark, and I think this is sort of a trajectory thing, right? So I'm much more junior. Like I'm only in this job for about 7 to 8 years. I only just made tenure. And so I'm sort of trying to think of ways to, now that they theoretically can't fire me, think of ways that I can sort of expand some of that reach in terms of engaging with this social determinants of health, the social ecological model, and other things that allow me to speak the language to be able to sort of get these kinds of courses further. The other two things that I wanted to sort of touch on very briefly, because I know we're kind of running a little bit late, is that one of the struggles, I think, for me as a junior scholar has been how to align with public health funding expectations. Specifically because I am not, like I said, the person who's doing the interventions. And it is the NIH funding is for the person who's doing the interventions, right? They want to see interventions. They want to see, even though there's a lot of speak about structural level and thinking about complexity, really what they're funding is, how do we solve this now? Not tell me what people think, but how do we make people do what we want them to do? And so it is this so what question that I get a lot of pushback from when I sort of do discussions on what I do, and also in funding perspectives, like, so what, why would we want to know? So where is the intervention? Where is the end point of this? And I struggle with that because I feel that they're being pushed to be reductionist in what I would like to do, right, in terms of the funding. So I was very lucky, I think, in terms of my tenure process to get an NSF funded project. It was a small amount. It was a rapid project on understanding reproductive decision-making and Zika in Peru when Zika was a thing a couple of years ago. And so that, for me, basically under my current leadership meant the difference between getting tenure and not getting tenure, right? I had that $20,000, which for them, public health is peanuts. But it was NSF. And therefore, that was sort of the point at which they were like, okay, well, she's got NSF funding. Okay, you can get tenure. But I'm struggling now as a sort of middle point because the type of research that I do is not generally NIH funded. And so I spoke to a couple of colleagues, and basically the way that I'm trying to work around that is in collaborations with people. And so I have a colleague who is doing a lot of survey design and measurement design, specifically around things that have to do with sexual behaviors. And so in doing a lot of this qualitative is important work early on in my time at Indiana, she thought, well, you know, if we want to do a survey design, we could do a whole lot of focus groups and interviews to be able to better understand this sexual behavior, which is kind of novel. And then we use that to actually generate different forms of pre-surveys and surveys and then a panel. And so, but building those collaborations takes time, and trying to sort of get across what that means in terms of what the value of your perspective from a qualitative stance is, also sort of takes time. And so I'm sort of thinking, I'm looking to Mark for some of the models that he has been talking about in ways in which to realign or think about how to engage with public health research, basically without losing your anthropological heart, is what my mind is thinking. So that it's more, or it becomes more than just you are the person who does the qualitative stuff, so that you're able to engage in that in some way. But I also want to say, just as a closing, that I find a lot of interest and a lot of value in the can-do attitude that is sort of inherent in our public health students, right? It's, well, we should do something about this. And I think that, and this may sound like, you know, as you are managing toddlers, this is really good, you need to do things, but let's figure out how you best do these things before you actually do them. And I think that is a good problem to have, right? There's a bunch of people out there who want to do applied things in the world to effectively make the world and health issues better for others, but may need some guidance or thought processes and training on how to do those things better. So that's sort of, yeah, what I wanted to say.
Okay, I think we've only got half an hour left, so I propose that I do my introduction and then we go straight to audience questions. So on that note, I'll try and mix in maybe everything. So very briefly, I found everybody's presentation so far fascinating. I feel a bit of a newbie in public health. So very briefly, my background is I did an anthropology undergrad in the early 80s. And then I had a career in international development where I did a master's in agricultural economics, and I was working on agricultural projects in Pakistan and Peru. And I ended up in Indonesia, and I worked for the World Bank, and the guy in the World Bank was sort of saying, well, you're an anthropologist, you know, I do health and education. He drew me into health, basically. So I started working on health systems in Indonesia, and then worked in various other countries, Lesotho and Ethiopia, and places doing water sanitation in Ethiopia. Then I decided to do my PhD in medical anthropology as a rather mature student in my early 50s, with a view to going back into international development. So I kind of ended up in the College of Public Health a little bit by accident, but I should mention that my medical anthropology I did at the University of Arizona with Mark Nichter. And Mark Nichter has always, you know, he has sort of one foot in anthropology, one foot in public health. So he kind of convinced me that, you know, with all the coursework I did with him, I do have enough public health to work in public health. Anyway, so I started going back into international development. Then this job came up as a lecturer in the College of Public Health at the U of A. So I thought, okay, well, I'll get some teaching under my belt, you know, I'll try it out. So I'm sort of in my 4th year, kind of still feel I'm a little bit feeling my way. And I don't want to repeat what's already been said, but I would like to just very briefly mention the setting and the challenge that I feel I'm facing. So the setting, we're in a College of Public Health that is very well respected. It's Hispanic serving, it has a lot of first-generation students. And their kind of flagship is community-based participatory research. So one of the things I've been trying to tease out is, do they mean the same thing that I mean by, you know, participatory research? Because working in international development for British Aid and so on, I was at the kind of height of the Robert Chambers participatory development movement. I don't know if anyone's heard of Robert Chambers from the UK Institute of Development Studies in Sussex, but he promoted an approach in international development of kind of, you know, handing over the stick, let the people, you know, determine what, you know, these donor projects should be doing, and sort of upending the whole foreign expert idea. That was his big thing. So it started a whole movement in international development called participatory action research, participatory development, where you try to let the people take the lead in determining what your development project is going to be. So that's been one of my challenges is, you know, do we mean the same thing? I'm in a department called Health Promotion Sciences. I'm still trying to work out what is that science? What do people mean by health promotion science? And I would say that my main approach has been listen to the students. So, and I've listened to students, some of the grad students have some medical anthropology, and I frequently hear from them, oh, you know, Priscilla, the thing with public health is that when people, so let me step back a bit. I was hired to teach 2 classes. I was hired on the 2nd of January to teach 2 classes starting in a week. One of them was qualitative methods for grad students as a seminar. And the other one was a large 100 undergrad student in global health. So, you know, they said, can you teach these classes? And I said, yes. So that was a steep learning curve. But then in the global health class, I had teaching assistants who had some medical anthropology. She said, and I said, what are these students coming into the classroom with? She said, well, basically facts, knowledge, you know, they're taught, you know, these are the facts about, you know, whatever the health issue is, but they're not really encouraged to think about different perspectives or whatever. And then in the qualitative research as well, the grad students had no background in anthropology. So the impression I had was that in a public health training, I didn't have the benefit of an MPH. There's a focus on facts. My department seemed to do a lot of needs assessments. And so typically I will ask a student, you know, what are you interested in your research? And they'll say health disparities. You know, 9 out of 10, they'll say health. So what research would you like to do? Well, I'm going to look at barriers and facilitators to access to X service for Y population. And so I hear this over and over again, and I sort of think, well, that sounds a little bit limited. Am I the only person who thinks that's limited? So the other day I was talking to a grad student. To my delight, she said, I said, what are you interested in? She's African-American. She said, well, I'm really concerned about maternal health outcomes for African-American population. So, and then she sort of said, so what do? I do another needs assessment. I can try and find out the barriers and facilitators, and that's my PhD. And she was sort of saying, that's not interesting to me, but I don't know what else to do because I'm in a College of Public Health and that's what I'm expected to do. So it's this kind of thing that I think, aha, there's an opening there. There's actually a demand for something beyond what public health seems to be about. So I kind of, I'm trying to look for open doors that I can put my foot into. But I think one of the main challenges that I'm trying to focus on at the moment is getting people to rethink how problems are defined in public health. And again, this thing that's come up before, instead of saying, well, we're starting with a service, and why aren't people using the service, to start with, people's everyday lives, what's going on in their head, where health even fits into that. And I think in terms of these theories, every student said, I want to use health behavior. I can't even remember the name of the model, social cognitive model, or I want to use social determinants of health or whatever. Not only do they really want to take a model off the shelf and apply it, but they also don't have the confidence even to modify that model. So I was in, I'm using case study examples because I'm an anthropologist. I was in a dissertation defense recently, and they were using looking at vaccination attitudes towards actually to the flu. Okay, so she was analyzing this data and she said, well, I'm using the intention to vaccinate model that the World Health Organization is using. So I read her thesis and I said, well, there's this concept of social risk, and there's this concept of hierarchy of risk, that people don't just look at the risk of one thing, they compare different risks. And she said, well, that's very interesting. I gave her some references and she said, but it's not in this model. So I don't think I can use that at this stage, and maybe I'll use it in the future. So, so that's another kind of, just these sort of little vignettes that sort of present these challenges or, ways in, that you can either see them as challenges or ways in. But one thing that I wanted to, because I think everybody's done a little bit about, well, what have you done? One of the most interesting things I've been able to do is co-teach a class with an epidemiologist who happens to be very open to social science. And and this is supposed to be, it's a master's level, MPH, and it's supposed to be a kind of capstone where they bring in, their training in culture and policy and epidemiology, and they bring it all together. So we're trying to combine epidemiology and anthropology in one class. And so I'll just end by with a couple of quotations from, and the first time I taught it, I just sat and listened. And I thought, again, the model that has been used for the last 10 years in this course is cram as much information as you can into these students' heads. And at the end of the course, they'll design a policy. And I sort of thought that policy is totally not grounded in, because it's a global policy. So they would come up with sort of a policy for health services in Nepal with no connection to Nepal. They'd never been there. So I thought, okay, what can I do with this course? The first year I just sat in, and the second year, which was this year, and we only had 5 students in the class. So I did 2 things. One is I put in a lot of anthropology readings. And the other thing is I built a global partnership with the University of Indonesia, where we actually had joint classes. We decided we'll focus on Indonesia, we'll develop a policy for Indonesia. So I developed this global partnership where we had some joint classes, which was really challenging because they're 14 hours apart. So it's either too early or too late for everybody. And so we ended up in this classroom with, our 5 students and I think it was sort of 35 Indonesian students or something. And, I just realized that our students are not me, they haven't been in Indonesia. They were just totally thrown in at the deep end and they didn't really know how to handle this. So we've got a lot of work to do, but that's just a couple of ideas. But I wanted to end with just a couple of quotes from students in that class. So one of them, Amelia, and I said, I know I threw you all in the deep end and this was all new stuff, how did you find it? Well, Amelia had a bit of background in anthropology and she said, well, my impression is, I quote, in public health, culture is almost presented as a barrier to health. And it seems to have become something that is only considered in relation to vulnerable populations. So that was very insightful, I thought. And then another student, Brenna, said, your course gave me exposure to other theories. In public health, we have social cognitive theory and we have social determinants of health, and they are huge, but you introduced me to some other theories. So I'll just end by saying that in my qualitative methods class, we actually do Bourdieu. We do quite a lot of Bourdieu, and the students have to do a presentation on Bourdieu and how it's, how it can be helpful for understanding health behaviors. And every year I actually do a qualitative research project with the students. So the first half of the semester, we're collecting data, and the second half, analyzing it. And then, they love to have a product at the end, a poster or a presentation or something like that. So looking at the time, I'm going to end there. And yeah, I suggest we just give you guys an opportunity to ask some questions.
I'm not sure I have a question articulated yet. I'm an anthropologist who stumbled into bioethics 20 years ago.
Stumbled into?
Bioethics.
Okay.
So I teach at Temple University School of Medicine. I run a master's in urban bioethics, which is sort of bioethics focused on focus areas.
Mark, can you hear?
For my first Anthro conference,
I can hear.
years. I was like, I need to get back to my roots. And this is the first panel that I saw today. So I guess I'm still formulating questions, but thank you all so much for sort of, it's nice to have your own tribe of people again. I'm not crazy. The issues that you all talk about, the space in between, the management, this trying to figure out how to convince a medical student that their patient's context is important. I don't know, I'm reeling and thinking about wonderful things. The difference between facts and knowledge, I love that.
I'm going to reiterate what you just said in the sense of like, this is my first AAA in 5 years. And I'll be honest, on Wednesday when I showed up, I wasn't sure I belonged. Just the feeling of, have I been too far away from everything? Definitely not 20 years. But
Bring up a chair. We're just having a conversation.
Conversations yesterday and hearing you guys, it makes me, it just makes me feel good about like, yeah, I am still an anthropologist. I still, it might not be the traditional, I'm not at the university, that might return someday. I got a feeling of like, I'm too far removed from it. I'm with Ascension St. Vincent Hall. I've had medical education residency programs. Foster.
I'm just going to say something because we've all talked about some similar themes, but even in a theory class, I mean, if you take any of the canon of public health, behavioral theory, most of it is empty constructs. What is a perceived barrier? What is perceived behavioral control? What is self-efficacy and all these other sorts of things? And so, I found that even in teaching, even in going through the regular canon, before we get to the other sort of anthro-related theory, the theory course, even asking students the question, you can't take this thing off the shelf, as you said, and just go and apply it in some population, because look at the constructs here. Perceived susceptibility. I'm just focusing on the health elite model for the moment, but what are these? They're nothing. I mean, if you think of these as some algorithm, there's no algorithm there. You need to fill in what any of this means for that population before you can even think of lining up these constructs in some row and making a claim, more or less testing a claim, that these have anything to do with why the person is doing X.
So one thing I would like to get feedback from other people is I'm wondering if, well, just to put it in a language that might be able to understand that public health people use these models, and we think about concepts. So when I was sort of saying to this person, you know, what about the idea of social risk, that somebody might think, if I get vaccinated, what impact will that have on my social networks? A concept is a kind of, it's like a seed, it's like a generative thing that it's good to think with. Whereas when people come to me and say, well, I do social determinants of health, that's, for me, in my head, it closes a door, it doesn't open a door. It's like, I've defined it, I'm a social determinants of health person, I'm a politically correct public health person. What does it mean? What does that actually mean to say that you do social determinants of health? I even stopped having a class on social determinants of health in my global health class, because everything is about social determinants of health. But I used to do Michael Marmot. I don't know if you're familiar with that, but he, was involved in the World Health Organization definition of social determinants of health. And he did these amazing studies in the UK civil service about, inequality in health and so on. So I used to do that, but I don't want to be the social determinants of health person. I kind of feel that's part of the problem, is that everybody thinks they're already doing social determinants of health, so they're okay. But without, anyway, I don't know quite why I went off on that. But
Just in the theoretical perspective, I think that one of the things that I try to tell students is theories are good to think through, which is what Mark is basically alluding to. It's like,
yes.
Okay, so this is what this person says. So what does that mean? How do I operationalize that? How do I think about it in a broader perspective? And try to move away from this idea that a theoretical model is predictive of behavior, which, our PhD is a PhD in health behavior. And so the students are sort of geared by our faculty in the theories class to choose a behavior and to choose a model by which they want to sort of seed in this behavior in several ways. And so some pushback on the theory is not predictive. And I had some really interesting discussions with the new faculty who's teaching that, who's a younger psychology person, who is not a public health person, but comes to public health from psychology, from counseling psychology even. And he and I sort of agreed that theories are good to think through and that they're not predictive of health behavior. And so I think that there's a really good potential for some of that change to happen if you conceptualize theories in a different way.
I think just asking the question, what is research about? I mean, I find a lot of the students are receptive to the idea that research, you're supposed to be discovering something new, and that often conflicts with writing a grant proposal where you're supposed to tell them exactly what you're going to do. And I think a lot of the time in my work, I find that the students get it way before the other faculty get it, because the faculty already have a professional identity. But I do feel they're beginning to, I mean, in the defense that I was in recently, both of the other faculty said, we really appreciate you bring something new, we read your comments in great detail. But there's still the but, there's still the, but I don't think we can, change this model at this stage. Or, I asked the student about the model, the intention to vaccinate model. I said, well, what do you think of the limitations of this model? The only thing she could come up with is, this is a new model and it hasn't been tested enough yet. So that kind of reinforces the idea that, a model is there to be tested, but yeah.
Even in the public health literature. Oh, no, yeah.
But this is if you're following up, I was going to ask if I could switch gears.
Yes.
Please do.
You have to talk to the computer.
I was curious and sort of thinking through culture, and in my world, I have learned to be very comfortable with what I think is sort of very much simplifying anthropological concepts for medical student audiences. And one of the biggest, most important concepts, I think, is the concept of culture. And I've been trying for 20 years to get people to see it as a verb and not a noun, and which is so antithetical to medicine, which is you are the expert, you have the one right answer. and culture as a process, as a verb, throws all that on its head. And I'm wondering I'm so impressed with the teaching with going to all the way to undergrad med ed, to the graduate education space. If you have any, like, do you still try? Like, how do you talk about culture?
Yeah.
Populations.
So this is a great question. It's actually what we really spend. So it just to give some background to this too, this is an area of fun tension between Robbie Bear and I that's been ongoing since we've known each other since 1997. So her and I debated, the role of culture and the role of other structure and in what that means and all those things, with some tension as to how to invoke and employ those concepts. First of all, this is hard enough as anthropologists. So now we're going to take these like concepts and try to, put them into medicine, into a space where they think the word anthropology or culture, it's these like static ideas of cultural competency, right? And I mean, actually, I had somebody from the hospital pull something out when I was getting permission to do a lot of these courses. I was in an executive's office, and they actually pulled out this. They were really proud of it. They pulled out this like brochure, and had Arabic, Spanish, and it had like a picture of a person and like, here's the 3 things they do. Right. And so like, I do try to remember that we're coming from this obviously complicated discussion about culture as anthropologists to, now people don't even have that understanding that there's debate around this concept. So how do we deal with this on a day-to-day basis? And what I would offer is that we really feel it's important to ground people in the basic understanding of illness, and that's kind of the proxy for culture to us. I think as that's where we invoke culture. We invoke culture around explanations of illness, and then that's traditional stuff. That's Klein and Good and Hahn, and then why are there disparities around those, experiences of illness or outcomes around disease? Now we start to move into, I would say, structural type of determinants. And I don't know if that happened. Like, I don't think we sat and planned for that to be the theoretical split that we like agreed on and like could get with each other. But I think that's what just happened over time doing this, is it seemed clear that was kind of the way to put these out and to teach to teach different concepts, and then to, sort of challenge to invoke the right concepts at the right time. And I think that's worked, and that carries over that carries over from the illness analogy into physician land, I would say, just in around kind of reified ideas of what provider behavior is supposed to look like and be. But I think that's the key part, though, is the illness concept versus disparities in outcomes.
So just to finish, I think that it is interesting. Just one thing that motivated this was the COVID-19 pandemic. Thinking about, okay, so that has really ripped the Band-Aid off a whole of the structural determinants of health from, public health speak. So is there going to be an impact? Will there be something for like an opening for that kind of more complex anthropological thinking in this space? What do people think? I'm going to go with you first, Jason, because you're like in the thick of it as an emergency medicine physician.
Sure. And I'll tell you too, we've got a paper coming in Human Organization that's been accepted, so it should come out soon. And it's really about that. It's what was very cool to see was that over the last few years, people did recognize that this weird team of anthropologists working in the ER kind of knew how to build systems of care really quickly in a way that at least was very patient experience focused and provider focused and could just get the job done. We had done it with opioids and HIV and firearms. And so when COVID happened, it was interesting because, we all of a sudden had to deal with this disease state we didn't know and result patients. And, do we keep them in the hospital, let them go home? We actually took our anthropology team who couldn't really do the same research they were doing because of restrictions and things like that around COVID. And we just turned them right over into doing COVID pathways and COVID building and COVID follow-up And I think it was incredibly successful, right? We just use those same skill sets to go out and, build a community clinic and do telemedicine and get providers comfortable with virtual medical care and get patients comfortable with virtual medical care, to get them to understand, to find barriers and limitations about how to use technology to participate in COVID care. And then, even to do research. Just a quick cool example, our county was debating whether we should have masks as a mandate during the peak of the COVID surge. And we did mixed methods, rapid qualitative research in the ED when people were getting tested about whether they were wearing masks or not and why. This is last year, and the rates of people not wearing masks were over 80%, with positive rates were over 80%, and with mask was less than 20%. Clearly a disparity, and it led to a county. I mean, the policy passed in the county we were invited, and so it was, I think, for people to see like a clear example of, oh, here's the way they do research and it's valuable, but also here's the way they can like assemble ways to think about patients is valuable as well.
I'm just going to add, we have, I'm sorry.
No.
We have a project, there's a, NIH has funded this 20 team, they call them Community Engagement Alliance Against COVID. There's 20 of these, and so we're part of this team that includes Hopkins and the Avance Center at GW and Morgan State and University of Maryland, Baltimore County. And it is a, basically there's a short formative, rapid assessment kind of process for trying to understand how people process information, how they think about information that's coming in about vaccines, about mask wearing, about other, testing, so on and so forth. And so there is that in a similar way that the anthropological lens comes in trying to understand how people are constructing COVID as something, is this the same as they would construct another, some other illness, and what do those preventive measures mean in the context of these different vulnerable groups? And there's a lot there that's, some of it's pretty obvious about, the mask wearing, for example, in a highly collective cultural situation where people, the risk, we were talking about risk, and this is really an important issue about the relative risk of wearing a mask in a context where the big fear, the big risk may be alienating that very important social support group, whether extended family or something else like that, and that may be a more salient risk than this distant notion of I might get COVID and so on and so forth. So we look at that, we look at information sources, and then we try to craft messages. It's kind of a rapid response, very dirty research, in a sense, effort, but it's an attempt to try and get at some of those things and then see if we can feed that into messages.
So we're at time for, so is there something you want to add?
Oh, just very briefly, when COVID first hit, there was like the epidemiologists were like everywhere. And in my college, they were just so active and contact tracing and all this sort of stuff. And I sort of thought, okay, I'm just going to stand back. Again, very much kind of chipping in on team projects. We've got a big project on vaccine perceptions that I'm kind of chipping in on. And I feel also the whole misinformation, disinformation onslaught has taken a lot of people by surprise, and it has really raised awareness of the need to understand those kind of, conceptual things and rumors and how they spread and so on. And again, Mark Nichter has been doing quite a lot of work on that, which haven't been directly involved in, setting up health workers hosted an NGO and promoting an idea of where you can go to the website and sign up a health citizenship pledge saying, I pledge to, access reliable sources of information and follow these things, and just trying to get this sort of general social movement to try to address some of this thing. But I think there are a lot of opportunities in the recognition that, it's finally sunk in that people's perceptions really do matter, and, we need to understand them. So if you want to add something.
So, I mean, I have a sense, and I'm not doing COVID research, but really I think I felt that there was a lot of push for people to do research, and I couldn't emotionally engage in research. So But I do think that there's a broader perception, and I see this specifically in the change in what the leadership in my school is sort of thinking about now, because the early point of the pandemic and into midpoint, like, I don't know if early or mid makes any sense right now, but let's say last year, all of it was, there's this money, you have to go get and do this grant. And I was like, you know what? I just can't do this right now. Don't talk to me about it. And now it's, oh, wait, people don't understand things. Maybe we should, think about how people understand or don't understand these things. And so I think that I sense a change. And I was at APHA. I wasn't physically at APHA, which is the Public Health Association meetings. I was virtually at APHA. But a lot of the panels and the discussions, and you can look at the themes, you can look at the program sort of meeting stuff online, were about this uncertainty around scientific knowledge and what knowledge meant. And I think that is really a wake-up call from a public health perspective on what people thought they were doing and what they were really doing, in a sense, in terms of this kind of approach. So I think that there is an opening there in some way.
Well, I'd like to end by, I think inevitably we tend to give an impression of being a bit negative about public health. And I just want to say, there's a very positive energy that you've also referred to. And it's really, I really enjoy, I don't know what Jason said. I mean, I do enjoy working in that environment where everybody sort of get up and go and future positive and all that sort of thing. So yeah, I think there are challenges finding an identity, but it's a great.
It is a very, I mean, I feel that the difference in the sense of how people feel at an anthropology meeting versus a American Public Health Association meeting is very patent. Like the reality of there's a bunch of people who really, really want to engage wholeheartedly in some really good activities to change things. I think is really a nice space to contribute with. Even as we have critiques towards it, I think it's a really great space to do some of the applied work, right, of anthropology. And I think that I came from an applied program as an undergraduate. Anthropology in Peru wasn't a theoretical thing. It was, how do we understand our country? How do we better serve the marginalized peoples of our population? And the expectation was that we would do something with our degree. Some of us, and this is what I didn't want to do, went on to work for mining companies and petroleum companies doing indigenous relationships kind of things, which ended up in different ways. But it wasn't something I wanted to do, but I did want to keep on feeling that I was doing something. And I think that working in this space of public health, both through education and through actual research, I do feel that I can live in that space of doing something that I think is really useful.
I'll just second that, Jason's probably true too. I'll second that whole, I mean, I think that is true. People come to public health school and then they do, there is that, as you said, can do, there is I would say a pretty broad kind of social justice motivation for a lot of people to go to public health school. They want to improve quality of life for, vulnerable populations, et cetera. So, I mean, that is, I mean, not that, I mean, anthropologists certainly do too, but it's kind of like, what can we, let's get to this, what can we do? So that is a good thing.
Yeah, and clinical medicine's like that too. But the interesting thing is, I think it's, the people who get involved in doing this type of research from that perspective have to go through this you used a Zen analogy earlier, so I'll use one too. It's kind of the same, like you have to go through this like transitional state of, you start out as a pre-medical student as the same kind of, gung-ho, I want to save the world person. Then you start to see the realities of what a biomedical healthcare system look like. And you kind of go one or two ways right there. You either just embrace it and go with it, or you kind of get a little disjointed and maybe dissociated with that. And then from there, it gets really interesting where people go in their careers. Some don't do very well. And then others, I think, kind of have these like epiphanies and sort of start to see the world and recognize we need to see the world a different way and want to bring in a different way to view things. I think that's where this type of work comes in. And, public health is, still kind of at that. We want to just quantitatively look at ways to solve the populations of the world's problems. And it doesn't mean there's not value in looking at large sets of quantitative data. It just it is a little dissociated from the reality of what people who see this stuff every day, I think, and which is what anthropologists do too, experience.
So just a final note in my, the course that I was talking about, which was the capstone course with the University of Indonesia, just to put you back in the picture, one or two students did write. I thought I wanted to go in global health, but now I understand the reality. I'm not sure I want to be involved in this business. Is that a good thing to get them to think the reality? I don't know. I kind of have mixed feelings about that. I don't want to put people off, but yeah, I think if you start opening things up like that, that's going to be, I think that's what you were talking about, Jason, as well, that some people are going to think, oh, help, what am I letting myself in for?
Thanks, everybody. I think we're out of time, and I think there's another panel here. Thank you very much for coming.
Thank you, everyone.
Thank you.
Thanks,
Thank you.
Jason.
Thank you. Appreciate it. Thank you. That was fun.
It was great meeting
I
you.
think Jason and all of us, I think we need to follow up with this as a possible.
Yeah,
an article looking at trajectories.
We were talking about maybe doing something for human organizations, so we'll be in touch. We talked
Okay.
about it yesterday.
I think that sounds great. I think it's really important to keep on continuing with this. And Adam Van Arsdale reached out to and asked if we needed any help with publication, stuff through AAA, he could try to help with that. So whatever. Yeah. So if we want to maybe start a conversation with him as well.
That sounds awesome. Thank you so much, Jason.
Yeah. Thank you. Sorry I couldn't be there with you.
We're sorry too, but it's been great.
Okay. Appreciate it.
Thanks. Bye.
Thank you.